Hi, I'm Mark from ACLS Certification Institute, and in today's video series we're going to review BLS, Basic Life Support for the Healthcare Provider. We're going to go through all the steps, make sure that whether you're a seasoned professional or brand new, we're going to go through all the steps so you'll be prepared for your exam. Now, I know a lot of you are saying, well, Mark, this is an ACLS class. I want to get on with the advanced cardiac life support. Teach me the drugs, show me the tubes. Let's talk about tachycardias, bradycardias, all the cardias. Bring on the cardias. Good ACLS, real ACLS starts with good BLS, good basic life support maneuvers. And the American Heart Association is emphasizing this, the importance of doing quality chest compressions before we deliver the shock, before we start our ACLS. So that's critically important. We're going to review that right now. Let's go through the steps. So, step number one, establish unresponsiveness. Shake the victim. And folks will ask me, well, how hard do you shake them? How much force do you apply to somebody when you're establishing unresponsiveness? Okay, that may be a little too much. Shake them like you're trying to wake up someone who's in a deep sleep. A sternal rub is always appropriate to establish unresponsiveness. Try to get some response from them. If you don't, immediately call 911, or if you're in the clinical setting in a hospital, call the code. Get some help coming. You cannot work a code alone. I've been in the field. You get called to a code sometime and it seems like this. Where's everybody at? There's no one around. I'm all alone. I need some help. On the other hand, I've responded to codes in the hospital. You call the code and you got this. You got everybody and their brothers showing up. You got dietaries showing up. You got Shriners on little tiny motorcycles circling the bed. That's where the role of the team leader comes into play, and we'll talk about that a little bit later, and not only managing the patient clinically, but managing the event. So, after you've established unresponsiveness, and you've called 911, or you've called the code, check for a pulse. This is where the healthcare provider is different than the layperson. The layperson doesn't check for a pulse. They just start chest compressions. But as healthcare providers, you want to check for a pulse. When you check for a pulse in the adult, we're checking a carotid pulse. Start here in the neck, slowly work into the crook of the neck till you find the carotid pulse. But spend no more than 10 seconds trying to find that pulse. Could come up on a test. No more than 10 seconds to check for a carotid pulse. So establish unresponsiveness, call the code, get the AED coming, get your defibrillator coming, and start chest compressions immediately. Chest compressions are probably one of the most important components of ACLS and providing ACLS care to the adult victim. So let's review chest compressions. Depth for an adult, at least 2 inches. At least 2 inches of chest depth when you're doing compressions on the adult. Chest compressions on the adult are done at the rate of at least 100 per minute. And you can use this song if you like to remember it. Yeah, the tune's Staying Alive. The AHA was using that in some of their literature and some of their advertising so that people get the rate of 100 down for chest compressions. So a rate of 100 per minute, and when you're pushing into the chest, we'll do chest compressions at least 2 inches into the chest. Remember to allow that chest to completely recoil. So when you're pushing down on the chest, remember to let that chest come all the way back up. Keep contact. Keep your hands and keep contact with the patient's skin when you're performing the chest compressions. This will avoid migrating around the body. All of a sudden you wind up by the neck where you don't want to be there. Chest compressions are performed on the lower third of the sternum. So if we're starting from here to here, chest compressions are going to be performed here. Above the xiphoid, but on the lower half of the sternum. Again, at a rate of 100 a minute, pressing in at least 2 inches. Nothing interrupts chest compressions. Nothing interrupts chest compressions unless you're actively analyzing to shock them, or you're actively shocking the patient, or we're providing ventilations before we have an advanced airway. If we're using mouth to mask or we're using the Ambu bag, that's the only time we're not doing chest compressions. Otherwise, somebody is beating on that guy's chest. If the patient has a pulse, you'll then assess for breathing. Do the head tilt, chin lift, Open the airway, see if the victim is breathing. If they're not breathing, you'll give them 1 breath of air every 5 seconds, either with mouth to mask or with the Ambu bag. Avoid excessive ventilations. The American Heart Association does not advocate hyperventilating the patient like we've all seen and we've all done in codes in the past where you're hyperventilating them. 1 breath of air every 5 seconds. And it takes about 1 second to put that breath in. So a nice controlled ventilation over 1 second. When performing chest compressions and ventilations, they're done at a ratio of 30 to 2. That's 30 compressions to 2 breaths of air. Prior to the patient being intubated, if we're just bagging or we're doing mouth-to-mask ventilations, they have to be synchronized. So 30 compressions at a rate of 100 per minute. Pause, give 2 breaths of air, or 2 ventilations, and then 30 compressions a minute, and continue that cycle. The AED or the defibrillator has now arrived. Continue the chest compressions until the AED is ready to go or the defibrillator is ready to go. Continue the chest compressions and then apply the defibrillator pads. When applying the defibrillator pads, remember you're going to go high right, low left. High right on the patient, low left on the patient, with the intent of making a heart sandwich. The heart should be in between the two defibrillator pads. High right, low left. We go high right because usually most implanted devices, pacemakers, defibrillators that are implanted in the patient will be under the left clavicle. And you can palpate and you can appreciate that. So your pad on the patient is going to go high right, low left, placing the heart in between the pads. Make sure your patient is dry. If they're sweaty or wet, you have to dry them off before you put on the pads. You cannot shock a wet person. This is not Sasquatch. This is my dad, the hairiest man in the world. If I were to put defibrillator pads on this guy, the pads would simply spring back up. The pads have to make good contact with the skin in order to deliver an effective shock. Additionally, the AED, if it's an automatic AED, is going to continue to prompt you to put the pads on until it can read the electrical activity and has good conduction from one pad to the other.
Place electrodes. Place electrodes. Place electrodes.
Next, if your defibrillator has an analyze button, press the analyze button to see if the patient needs to be shocked.
Do not touch patient. Analyzing rhythm.
The machine is now looking at the cardiac rhythm and saying, do they need to be shocked or do they not need to be shocked? Which is all a defibrillator does. It looks at the electrical activity of the heart and determines whether a shock needs to be given or does not need to be given. Remember, a defibrillator cannot tell if the patient has a pulse or if the patient is breathing. That's your job.
Check pulse. If no pulse, give CPR.
Now, during the analyze phase, that's when you stop doing chest compressions. Chest compressions are continued all up until you hit that analyze button or the machine prompts you to stop doing chest compressions because it's analyzing to see if the patient needs to be shocked.
Charging. Stand clear. Push flashing button to rescue.
You must stay clear and you must look from the head to the feet of this patient to make sure no one is touching this patient when you deliver the shock or else they're going to get shocked too. Immediately after defibrillation, as soon as you shock them, immediately begin chest compressions again and provide at least 2 minutes of quality chest compressions, then assess for the pulse. After that 2 minutes of chest compressions, reanalyze to see does the patient have a pulse, has there been a return of spontaneous circulation and respirations, or do they need to be shocked again? You'll continue this cycle of shock and compressions until the ACLS portion of this begins. Again, we're talking about basic life support for the healthcare provider. Remember that most of the sudden adult cardiac arrests are in VFib or VTAC when they arrest. VFib is that chaotic electrical activity of the heart, and the only thing that is going to convert them is rapid defibrillation, shocking them as quickly as we can. Good BLS makes the ALS more effective. Good quality chest compressions prior to shocking them help to make the shock more beneficial. It helps it to work better. So good quality chest compressions are important. I'm Mark from ACLS Certification Institute, and thank you for watching today's program.
It's like a